fatigue. Vision was 20/25 on both eyes, and then J10 on the right, and then J16 on the left. The rest of the evaluation was unremarkable. At the end, the patient took out his phone, leaned back with an outstretched arm to read a text message. So this is introduction to our discussion today, no, optics and refraction. So what is optics? So optics is the science of vision. No? Can you hear me? Sorry.
Yes, Doc.
Sige. So there are four general classes, no, or sa optics. So this is the physics part. No? So there's physical optics, there's geometric optics, physiologic optics, and neuro-ophthalmic optics. So physical optics refers to the physical properties of light. So this is your physics lessons. We also, I'm sure you've encountered geometric optics also during high school and early college physics. So this entails bending or focusing light or images in an optical system. In our case, in ophthalmology, it's focusing light onto the retina. There's also physiologic optics, in which this refers to the process of um, producing energy, visual energy and stimuli at the retina. So when the light reaches the retina, its function is to process the light into electrical and energy to form neurotransmitters. No? And neuro-ophthalmic optics refers to the conduction of visual energy or stimulus to the occipital visual center, meaning from the retina and the optic nerve all the way to the visual center, which is in your occipital lobe. Okay? So again, what we're focusing this afternoon is going to be on geometric optics. So it's the process that occurs between physical and physiologic optics. So it begins when light strikes the eye until it reaches the retina. Beyond the retina, it's already this is outside the scope of this afternoon's discussion. So the basis of this geometric optics is refraction. So let's talk about vergences. No, so this is a measure of converging or diverging light. So when we talk about refraction, we talk about vergence. So when light passes through an object, it is bent. No, so if when light passes through an optical system, it either is converged or diverged based on the type of lens used. So when we measure it in diopters or prism diopters. So divergent lens is causes negative vergence, meaning it scatters light, and convergence, which is positive vergence, focuses light. No vergence is light is parallel, so it is neither focused nor dispersed. Okay, so all light from a certain point will divert. It's usually divergent. Okay, unless it passes through an optical system. Now next we'll talk about refractive indices, no, or index of refraction. So what is it? So it's the effect of an optical substance on the speed of light expressed as index of refraction. So meaning as an object, as light passes through an object, um, it is how the light is being manipulated or bent through when it passes through an object. So a medium changes its speed of light, especially if the two interacting media have different refractive indices. So the higher the index, the slower the speed. Okay, so air has a lower refractive index compared to water. No, air is only it's almost 1. Water is 1.33. So the greater the refractive index, the greater the refraction. So the more it is able to bend light. So Snell's law states that light traveling from a medium of lower index to a medium of a higher index, the light passes towards the normal. So let's say, for example, you have a glass of water, no? So light passes through air, it hits the air-water interface, it goes towards the normal. So what is this normal? Normal refers to an imaginary line that passes perpendicular to the surface of the refracting surface. Okay, so panglitan, for example, this is the surface of the refracting surface. So what air, water. So this is the normal, which is the line perpendicular to that. So, di ba, Snell's law states from a lower index of refraction to a higher index of refraction, the light is bent toward the normal. So it is bent toward here. Okay? Can you see you can see, Ramano, what you call this? The pointer. It's this one.
Yes, Doc.
Mas claro, no? Okay, sige. Conversely, from a higher to lower index, light is bent away from the normal. So, for example, the light is shown from the water instead through to air. So, if the light is like that, instead of going closer to the normal, okay, since it is a lower refractive index, it goes away from the normal. Okay? The opposite is true. Okay? So in this case, air passes through. So this is the air glass interface. So this is a perpendicular line. That is the normal. So the light is bent toward the normal. So in this case again, so the light from a lower index of higher index, higher refractive index to a lower refractive index. So the light is bent away. It's now bent away from the normal. See? So hypothetically, pangitan, you guys go spear fishing, you're trapped on a deserted island. So you see a fish in front of you. Where do you make your where do you stab the fish? You don't stab the fish where you see it, you stab it slightly in front of where you are. So that is one of the applications of Snell's law. So let's talk. So we're done talking about the basics of refraction. Now let's talk about the optics of the eye. So the eye has a lot of refractive surfaces, but the most important are the cornea and the lens. So among these two structures, the cornea is the structure that has the greatest refractive power at around 43 diopters. So the eye's refractive index total is about 60 prism diopters, two-thirds of which are contributed by the cornea. The lens gives about 19 to 20 prism diopters. So the refractive index of the cornea is 1.37. Okay? So a decreased vision may be due to a different axial length or different refracting powers in different meridians or in different axes. So these defects can be corrected by spectacles or contact lenses or even refractive surgery. So this is just an example of the reduced schematic eye. So this is just a diagram on the various lengths of the eye and its different focal points. This is just good to know. Okay? Just know that the refractive power of the eye is about 60 prism diopters. And average axial length, or meaning the length of the eye, is about 22.5 millimeters. So, when we do a pinhole examination, I'm sure you guys you talked about already how to do a visual acuity. When we do pinhole acuity, it minimizes the scattering of light and it reduces the blurring of vision. So if patient has a refractive error but has no other pathologies, when you do a pinhole, the visual acuity tends to improve when you do pinhole. Okay, it estimates potential visual acuity of the patient. So this is a Snellen chart on your sorry, on the right hand side of the screen. So for example, the patient's visual acuity is 2100. Imong ipinhole, the patient's vision improves to 2040. So patient is candidate for glasses. Okay? Next, we'll talk about accommodation. So what is accommodation? So this is when you, in response to focusing on a near object, the refractive power of the eye changes. So this is based on the ability of the ciliary muscles to contract and the lens to be more convex. So just remember the near reflex has three components. First is accommodation, next is convergence, and third is meiosis. So what happens when you accommodate? So during accommodation, the ciliary muscles they contract. No? So in the normal resting state, the ciliary muscles are relaxed. But then when these contract, the zonules loosen. The lens, in its natural state, without zonular tension, wants to increase its AP diameter. So meaning, if you remove all the zonules, the lens wants to be tambok. Why? Because of the shape of the lens. So it's the zonules that keep it taut, that keep it less spherical. So when the ciliary muscles relax, the zonules become when the ciliary muscles contract, the zonules become relaxed. So the lens becomes rounder, thereby increasing the refractive power of the eye. So for example, when you look at a far object, no, the light is focused at the retina. But when you look at a near object, it's the light focuses behind the retina. The focal point is moved behind the retina. So the ciliary muscles contract and the lens becomes thicker so that the light is now focused at the retina itself. So for example, this one, you move, the focal point is behind the eye. So what you do? Accommodation happens. And then the light is now focused squarely on the retina. Okay? Okay pa guys? Kaya? Kaya? Or you guys wanna take a break and ask questions?
Okay
Kaya
pa,
na, Doc.
Doc.
Okay, Ramo? Don't have any questions? Klaro ra, tanan?
Yes, Doc.
Oh, okay, sige. So let's proceed to refractive errors. Let's start with presbyopia. So presbyopia is defined as the decreased ability to focus on near objects when corrected distance vision remains normal. So it develops usually with age and presents at around 40 years old. When you become older, the lens becomes hardened, or it becomes stiffer. So it does not become more spherical anymore. So how do you treat it? You put plus lenses or bifocal as reading glasses or bifocals. So these are reading glasses and bifocals kay doble vista. So there's distance and there's near. Okay? Other refractive errors include hyperopia, myopia, and astigmatism. So hyperopia refers to farsightedness, meaning they can see they can see far, but at near malabo, no? Or myopia, which is nearsightedness, bali. Very clear at near, but very blurry at far. Emmetropia refers to the absence of a refractive error, so normal, good. There's nothing wrong. Astigmatism, on the other hand, means that the cornea's refractive power is different in one meridian than in the other. So ametropia defines the absence of emmetropia. So meaning if you have ametropia, you may either have hyperopia, myopia, or astigmatism. Let's start with myopia. No? So myopia refers to, again, nearsightedness. So when an object is focused at a distance, in an unaccommodated eye, the light is focused in front of the retina. Okay, so as the object is moved closer to the eye, the image is more closer to the retina and becomes clear. So ang distance hanap. As the object is moved closer, the focal point is now moved onto the retina, thereby clear ang near vision. Patients with high myopia, these patients are prone to having changes in the retina that may develop into retinal detachment. So there are two general kinds of myopia. There's refractive and there's axial. Refractive myopia means that the elements of the eye are more refractive than average. So because the lens or the cornea or rather the cornea has a very high refractive index, or the shape of the cornea increases its refractive power, light is no longer focused at the retina but rather in front. Or conversely, the eyeball is long, so the cornea and the lens can normal ra ilang refractive power, but the light is focused in front of the retina because the eyeball is long. Gets? Okay? Sige. There. In hyperopia, it's the opposite. So the images are focused behind the retina. So at distance, because the focal point is far away, clear siya. Okay? So when when an image is sorry, um, these patients are prone to eye fatigue because they have to make sure that they accommodate more in order to create a sharp near image. So in patients with low or moderately hyperopia, they can see well in near and far when they're younger, but as they get older, presbyopia sets in. This is when they notice that their near vision isn't as good. So as mentioned a while ago, di ba, refractive myopia means that the refractive power of the eye is too much. So this is the opposite. So the refractive power of the eye is less than that of normal. So the light is focused behind. Or the eyeball is short, the lens and the cornea are normal ra, but then the length of the eyeball makes it so that the light is focused behind the retina. Now in astigmatism, this is due to the shape of the cornea. So the eye now has images with multiple focal points. Usually, it's because of the cornea, but the lens can also contribute to astigmatism, also known as residual astigmatism or lenticular astigmatism. So there are different types. So there's simple, there's compound, and there's mixed. This is good to know. Okay. So in astigmatism correction, we want to get to the point of the circle of least confusion. Okay. So this one is just good to know. You don't really have to you don't have to study this. Just so you know that we have to get to the circle of least confusion by giving appropriate cylinder lenses. So in children, most babies are hyperopic. Why? Because their eyeballs are shorter. As we age, the hyperopia decreases. That's what we call the myopic shift. In the teens, in teenage years, usually around 17 to 18, there's an acceleration of this myopic shift, and eventually, adults are emetropic. Most errors are inherited, but then there's no one factor um, that is responsible for refractive errors. Okay. So when you're young, smaller eyeballs, then there's a myopic shift. Sometimes masubraan, the patient now becomes myopic. Okay. Question: is it possible to be myopic and hyperopic at the same time? The answer is
Yes.
yes, because there's what we call anisometropia. Could be one eye has a refractive error, the other one is emetropic, the other eye is hyperopic or myopic. Or could also be one eye is hyperopic or myopic, but there's a difference in the refractive errors of both eyes. So minus 1 ang right, yung left kay minus 3. That's a difference. So anisometropic. Or mixed. One eye is myopic, the other eye is hyperopic. Luoy na gini si patient. Okay? This is the major cause of amblyopia in children. Okay? Because one eye is able to focus, the other is not. So refractive correction is complicated by the size of the difference of the image on the retina. So this is what we call anisoconia. Okay. So in general, spectacle correction creates a more larger difference in the retinal image. by about a quarter of the size. Contact lens is better in cases of anisekonia. Okay? So how do we manage? So in patients with hyperopia, di ba, the images is focused in front or behind the retina in hyperopic patients. Anyone?
Behind, Doc.
Hello?
Behind.
Sorry?
Is it for hyperopia, Doc?
Behind. Very good. Behind. Because again, it could be the eyeball is short or the refractive power is not so much. So what we do, we put a converging lens or a plus lens. So we want to focus light on the retina. The converse is true. In myopia, light is focused in front of the retina. So we want a lens that is less powerful, that causes light to diverge. So we're going to put a divergent lens or what we call a minus lens. In astigmatism, we use a cylinder lens. Okay? Gets her, guys?
Yes, Doc.
Okay, so in patients with what do you call this? When we prescribe glasses, there are three components. No, there's the sphere, there's the cylinder, and there's the axis. Sphere refers to the correction of the spherical problems, no, myopia or hyperopia. Cylinder refers to the correction of astigmatism, and the axis is the degree or of the angle in which the cylinder is placed to correct the cylinder or to correct the astigmatism. Okay, so the sphere minus 250. The cylinder refers to the cylinder that is placed in front to correct an astigmatism of about minus 25 at axis 180. Gets? So for example, plus 1 sphere, minus 175 cylinder at the axis of 60 degrees. Okay? To get to the circle of least confusion. Yeah. Okay? So the safest method to correct refractive errors is spectacle correction. It's the most affordable also. Contact lenses are another option. Rigid contact lenses correct the refractive errors by changing the curvature of the surface of the eye or the anterior surface. So it overcomes the corneal astigmatism by the modification of the anterior surface of the cornea into a more spherical shape. So this is usually indicated to correct irregular types of astigmatism. Whereas soft contact lens are flexible, they adapt to the shape, but they correct little lang of the corneal astigmatism. So scleral contact lenses, are they right for you? Depends. So this one is a rigid contact lens. Okay, since rigid man siya, it has more initial discomfort but allows oxygen to pass. It's very good durability because it's rigid and is used for extended wear. However, because it is smaller than the cornea, it's easily dislodged and it takes a longer time to get used to it. This is a soft contact lens. It's usually larger than the cornea. Its comfort initially it's greater because it's soft, no? But it causes more dry eye because it moves around, less durable, and eventually is better for intermittent needs shorter adaptation time. Okay? Here's to the cornea surface kasi soft man siya. Okay? Then, if dili comfortable si patient with glasses, not comfortable with contact lens, refractive surgeries can also be considered. So these change the curvature of the anterior lens surface, the corneal surface rather. Or you can also implant an intraocular lens, either by replacing the natural lens or placing an intraocular lens in front of the natural lens. Basically, refractive lens exchange or basically cataract surgery can be done in patients for refractive reasons. Okay, so there's LASIK. and cataract surgery. So yearly, usually we have glasses yearly. No, I advise patients to have them corrected yearly. But if the patient's refractive errors worsen mga 2 3 times a year, then it might be a consideration of other corneal or lenticular pathology. Okay. So yeah, that's the last slide. Are there any questions? Anything you guys want to clarify? Refractive errors or any glasses related questions? Yes, sorry. Um, Salem, eh? Sorry. How do you pronounce your name? Sorry, who raised their hand? Can't, no, no, no. Hello? Sorry, who was the one who raised their hand? Anyone?
Jen, nag-raise kasi mong ay, Doc, na pistitan lang daw, Doc.
Okay, sige. Um, oh, tips lang for contact lens wear. Please lang, yun, please do not use tap water to clean your contact lenses. Please do not sleep with your contact lenses. Please do not bathe with your contact lenses, ha? And if your eyes are red, please, please, please do not wear them. And it, and if you do this, if you accidentally sleep with your contact lenses on and your eyes are red, please seek ophthalmologic consult as soon as possible.
Thank you, Doc.
Sige. So are there any more questions?
None
None,
so
Doc.
far, Doc.
None?
None so far, Doc.
Okay, sige. So I think that's it. It's a relatively short lecture, guys. So I think that's it.
Thank you, Doc.
Thank you, Doc.
So sige,
Thank you,
boss.
Doc.
On to ang restaurant. Sige, guys. Sige. Thank you.
Thank you, Doc.
Sige daw.